treat your ears like you would treat your eyes. When you have a vision problem, you go get glasses. No questions asked. But for some reason, for hearing loss, people are very reluctant to do something about it.
Hi everyone, welcome back again to Medifly podcast. I think this is around the 4th or 5th episode, and today I'm in SJMC. I'm together with Dr. Jeyanthi Kulasegarah, who is a specialty in ENT. So she's a consultant, ear, nose, and throat surgeon in SJMC with a lot of qualifications. So I think if I read the qualifications one by one, I would actually misspell it. But there's a lot of qualifications that we can cover. Maybe you would want to introduce yourself a bit, doctor, before we continue.
Okay, so I'm Dr. Jeyanthi Kulasegarah. I'm working currently in Subang Jaya Medical Centre. So I went to medical school in Royal College of Surgeons, graduated in 2001. After a year of internship, then I started my surgical training. So surgical training in Ireland, so I trained in Ireland, is quite a long training process. So you have 2 years of basic surgical training, and then we've got an exam at the end of that. And then went into ENT specialty training, and that's 6 years, and then there is an exam at the end of that. In between that 6 years of training, I did a PhD, which was about 2 years. So in total, my entire training, I think, if you do the maths, is about 12 years. It took some time because in between I was doing some medical officer posting for about 2-3 years. So it is a very extensive training. Now, once we are qualified as an ENT specialist, then we do fellowships. So I did 2 fellowships, one fellowship in Auckland, which is in New Zealand, which is a pediatric fellowship, and a second fellowship in Birmingham, which is in the UK, which is a ear and a skull base fellowship. Yeah, so finally, after all that, I returned home to Malaysia in 2017, worked in University Malaya until 2025 when I finally joined Subang Jaya Medical Centre. So, yeah, from 2001 to 2017 was the whole entire training process.
Thank you very much. Oh wow, we have you in this podcast is really, really amazing and such an honor. You mentioned you took PhD, right, doctor? As far from my research, I know that a lot of ENT don't actually take PhD, but you actually took clinical medicine in Trinity College Dublin, right? What draws you into research, and what do you think that changed from how you operate today as well?
So I had a gap year of 2 years, so I thought it would be quite useful to embark in something very different, just to widen, perspective. So I thought we'll try some lab-based research, because a lot of research that we do is clinical-based, so it's based on patients and data that we get from patients. So lab-based is very different. You're actually in there on your own, trying to figure things out. You're taught to do different experiments. So it was a totally different, eye-opening process, and I'm glad I did it because it just taught me different aspects like time management. I have to manage my own time. It taught me how to process data, to present. That is where my whole presentation skills really took off, actually. Yeah. So it was really useful.
Oh, okay. I saw as well in your profile that the number one mention was pediatric ENT, right, doctor? Did it start from your fellowship, as you mentioned, or is there any reason why you decided to also specialize and focus in pediatric ENT?
Yeah, so the training in Ireland is such that during that 6 years you're put in different, so ENT is divided into nose, which is rhinology, ears otology, head and neck, there's laryngology, and there's pediatric ENT. So during my ENT posting as a trainee, I really enjoyed it, and otology. So that's the reason I did 2 fellowship, because I thought, I want to deal with ears, but I also want to deal with children. So the tricky thing about children is it covers everything in ENT, but in those little people. So from airway, from hearing, so it's quite broad. So I think it was important for me to do a fellowship in pediatric to broaden my exposure.
That's really nice. I think it's because also children has higher risk towards all this. Is it correct, doctor? I hear that in Indonesia, this is because I'm from Indonesia, and probably a lot of the people watching this are also Indonesian. I hear that a lot of children in Indonesia are actually diagnosed with like hearing loss from the early stage. Is it really actually common for children to have hearing loss?
So hearing loss, there's 2 types of hearing loss. One, you're born with hearing loss, which is congenital hearing loss, and one is acquired, means you had hearing, and as time goes, you're losing your hearing. So the children who are born with hearing loss, those days we didn't catch them early. So the first 4 years of life is very important. That's when the whole hearing mechanism is taking off, you're learning language. So that 4 years is crucial. So we were missing the boat. So this is where hearing screening came about. And in a lot of places, hearing screening is compulsory for all babies born. In Malaysia, most hospitals have it, but it's still not in every hospital, because it involves the equipment, it involves staff, so it's not easy to execute this compulsory screening process. So in certain third world countries, this screening process is limited. It's only for high-risk babies, such as your premature babies. So we're trying to make sure that all babies get screened, and it used to be the 1-3-6 rule, where you detect it within a month of their birth. By 3 months, you need to confirm the diagnosis. By 6 months, they have to have a hearing aid on. And we're trying to bring that even closer to 1-4. So this involves a multidisciplinary team to make this happen. It's not just ENT, it's the audiologist, the pediatrician, the obstetrician, because the counseling happens when the parent, when they're expecting the baby. So that's where the counseling happens. So it involves a big team. So it'll take time to fully execute this universal newborn hearing screening.
So say, for example, if they already did like the 1-4, 1-3-6 as well, and they're like clear from all of these diagnoses, is it possible that it shows up during their first year or second year? And what are the symptoms that usually show, so that the parents know that, I have to take them back again for another screening?
Yeah, so when we do the screening or otherwise, we always tell the parents to monitor the child's development. To look out for the babbling, the eye contact, their first words. So if there's any delay, it's best to come and see a specialist early, so we can kickstart the process of referring to the audiologist. The audiologist will do some detailed testing. So it is also just, if the hearing screening is normal, doesn't mean everything is good and that's it, end of story. No, you still have to monitor the baby's development.
I think the most common I see in Indonesia is the middle ear section. I'm not sure if I'm pronouncing this correctly, but it's called glue ear. And I think a lot of people are actually thinking, the children will actually grow out of it. It's because they're small, it's going to grow out. Is that something that's really common?
Yeah, so just to bring you to this, so glue ear is because the space behind the eardrum fluids collects fluid. The reason being is this tube called the eustachian tube is not functioning properly. In children is much shorter and more horizontal. And at the back of the nose, because the opening is at the back of the nose. So this is where the eustachian tube opening is. So in children, they have, large adenoids, which is blocking the tube. So that is the reason why fluid accumulates. And if you can imagine yourself underwater and trying to hear, you can hear, but the clarity is not there. So that's why don't ignore fluid in the middle ear, because it really impacts the child's learning capabilities. They're having to strain, they're not catching everything, so the clarity is not there. So best to get it checked early and get it assessed, because there are ways first to improve the hearing, and so that the child can function to its, to their best capability.
You just mentioned something about screening, and the only thing I know about ear screening is that they will show you a number saying that, oh, you have a 60 decibels and all that. But I think us that are not in the medical field, we're having a hard time to actually understand what the numbers mean, right? So if like a patient's seeing you and then you're showing them, okay, there's 60 decibels and all that, would you mind explaining what those numbers actually mean for you, doctor?
Okay. So a hearing test tells us how bad the hearing is, okay? So rather than focusing on the numbers, it is whether the person has mild hearing loss, moderate, severe or profound hearing loss. So to tally the two, mild hearing loss is between 40 and 20. Moderate hearing loss is between 60 and 40. So the bigger the number, the worse your hearing is. You want your hearing to be 20 and under. So, rather than focusing on numbers, I think it's best to ask the audiologist or your ENT doctor, do I have mild hearing loss? Or is it moderate? Is it severe or profound? So it is the severe to profound group that we really have to focus more on, because this group, the first thing to try is hearing aid. Hearing aid amplifies sound. It does not give normal hearing. So by amplifying sound, how much have we improved their hearing capabilities? Because when we look at the numbers, it looks great, but what they perceive may not be great. So we go with how they feel when they put the hearing aid on, because in reality, we are in a very noisy world. So hearing aid also captures all the background sound. So it doesn't just capture someone talking. It also captures background sound. So sometimes in a noisy environment, their understanding may still be impacted despite wearing a hearing aid. And it is that group of people that we would then talk about an implant, a cochlear implant.
So a cochlear implant and a hearing aid is a completely different...
Very different. So a hearing aid amplifies sound, so acoustic sound. So you hear it as we hear it. But cochlear implant is a different type of hearing. It actually is more sort of a digitalized hearing, electric hearing. So it works completely different. One doesn't require surgery, the other requires surgery, and it works in completely different ways.
I read one of your journals as well. I didn't read the entire of it, but I know that you wrote about like bone bridge, BAHA, and all that. I think it's a lot of medical terms, and for families that whose kids needs hearing aids, it might be really confusing which one fits which child. Do you want to like elaborating more on which kid do you think fits which child, and how do you assess that?
So with any assessment, we start with, what is the problem, so the history. Then we look at the, what is the ear looking like. So we have a look at the, the outer ear, is it normal? the ear canal, the middle ear, is it normal? So it all depends on all those structures, and the hearing test also guide us what type of hearing loss it is. There's two types of hearing loss. One is called conductive hearing loss, and the other is called sensorineural hearing loss. So conductive meaning the sound isn't able to reach the inner ear. So just to bring your attention to this. So when you have a conductive problem, the problem is somewhere here. Either the sound is, there's something blocking the ear canal, something wrong with the eardrum, or something wrong with the three little bones of hearing. So anything along this path will cause a conductive hearing loss. Anything wrong with the cochlea or the nerve of hearing or the part of the brain involved in hearing, that is called sensory neural hearing loss. So two types of hearing loss. So we have to see what type of hearing loss. So a bone bridge is where we put the hearing device on the bone, because hearing via bone, it bypasses all this, and the sound is transmitted via bone to the hearing organ. So that is how a bone bridge works, which is quite different from the normal hearing aid. The normal hearing aid, the sound has to travel through the normal ear canal, eardrum, little bones of hearing before it reaches the inner ear.
Okay.
So it's quite complicated. So I think rather than focusing which one is suitable for my child, it's best to get the assessment. Once we as professionals see what type of hearing loss, we will decide which device suits the child, and take it from there. Because otherwise, it's a lot of information, with AI, Google, you name it. All that information is out there. It's so accessible, but I think people don't know, what's appropriate for them. So rather than trying to, it's a lot of information. So it's best to speak to a specialist. Get your assessment done first. Then the next step is what device.
So far, what we know so far about ENT is mostly about hearing aids and hearing aids and hearing aids, right, doctor? I think that's the most common that we know. But is there any other types of common things that you found in children that might not relate to hearing aids that a lot of parents might not realize at all, even?
Like you've mentioned before, glue ear is something so common that causes hearing loss, which is easily missed and easily corrected. So I think, and also ear infection. Please do not take ear infection lightly. A discharging ear, very often parents it's a little bit of a discharge, we'll see what happens, and that's left for weeks. Sometimes these are signs that there's something more going on in the ear, so don't ignore a discharging ear as well. Do get that checked, because these are things that can be corrected quite easily before it causes damage that cannot be reversed. So yeah.
Okay, well, I guess I wanted to ask you, what will be one advice if you can say to parents about their children?
So that's one advice. Yeah. Second advice is treat your ears like you would treat your eyes. When you have a vision problem, you go get glasses. No questions asked. Can't see, struggling, you get your glasses and you're settled. But for some reason, for hearing loss, people are very reluctant to do something about it. It's completely ignored. So just treat your ears like you treat your eyes.
Thank you very much, Dr. Jeyanthi, for coming on to this podcast as well. I think we'll have a second part as well on talking about the adult, because right now we're just talking about children, right? And I don't think we should mix it together as well, because parents and people in different age might watch differently. So thank you very much for joining me in the first part. I'll continue with the second part after this, but thank you very much for joining the first part. If Any of you have further questions for Dr. Jeyanthi, she's in Subang Jaya Medical Centre. It's actually in Kuala Lumpur. It's pretty nearby the airport as well, so it's pretty convenient to travel around. But if you have any further questions you want to ask, you can feel free to comment down below. Hopefully next month or the month after I can come by again to answer all of the questions that people have and have another podcast with you. Or I know that you have a social media that you often post around as well, Doctor. Is it okay if
Yes, do share. It's JENT. Feel free to browse and see the content in there. It covers not only hearing and ears, it covers a lot of other things. Thank you for this opportunity and looking forward to the next podcast.
Amazing. Like, comment, and subscribe, guys. Bye-bye.